CCGs are using collaboration with engaged consults in order to, we hope, alleviate pressures on primary care and to enable that collaborative working. We will also be looking at how bulk messaging, which is a new feature within engaged consult, how that can work for you. So if you're not yet using that as a feature, it is available, and we'll be showing you later on in this presentation how that can work for you. And we will also be speaking about our mobile check-in functionality for our patient check-in screens. Without further ado, I would like to introduce our first guest speaker, Nick Harvey. Nick is a GP partner, trainer at Park Practice in Sussex. He is the chair of the South Downs Health and Care Limited and clinical lead for Digital First at Sussex Health and Care Partnership. Nick, thank you very much for joining us. I will hand over to you.
Thank you. Can you see my screen? Perfect.
Yes, we can. Thank you.
Thanks for that introduction. So, yeah, as Catherine said, I'm a GP, and I've got a presentation that I'm going to try and rattle through to the beginning, because I think it's important in all of the actions that we do that we have some basic principles in place. And just to talk through why are we doing online consultations, first of all. I mean, I think the main driver for a lot of our practices is now mandated. Centrally, they're saying, well, could there be savings in this? And we don't really know yet. But there's something around convenience of access, something around safety and quality, potentially. Could it be more efficient? A lot of practices say it's not, but I think there are ways in which we can be. I think the other thing to bear in mind, though, is the real flavour of the day at the moment is to try and personalise care and empower people. So we need to keep that in mind all the time too. I think everyone here knows what online consultations are. I think it's important to note that the NHS England require it to be initiated by the patient. So it's not good enough for us to send a message via AccuRx or something and call that an online consultation. That doesn't count. But admin stuff does count, and we're finding that actually that's a huge area where patients and practices are finding benefits, especially efficiencies. So what's the context? Why are the government pushing it? I think it's important to bear in mind that the spending is just going up and up and up. Health care costs are huge compared to social care, but yet the funding that we're actually seeing is going up, but the benefits that we're seeing are becoming less and less. People are predicted to be getting older, but actually over the last few years we've plateaued. So we're spending more money, but not getting any increased life expectancy from that. And there's loads of other things. We're doing worse things for ourselves. So there's an important agenda around how we empower people to do the right things. And I think online consultations can be a tool to help us focus on that personalisation. That's key. Another slide just to show how we're getting more and more obese. So it's now normal to be overweight, this slide shows. And that's why we're seeing that plateauing of life expectancy and possibly a dip. This is about activity as well. So we're not as active as we should be. So this is the old model. The power was really with healthcare professionals, tertiary care at the top, primary care still quite high up, with really self-care being pretty much off the map. What we were looked on as the fixers, and patients being fairly passive, and we think we need to kind of flip that on its head. So information age medicine says that we need to encourage self-care and actually discourage that mentality of looking on us as medics as fixers and more as enablers. So online consultations are really, I think, key to that approach. This is another thing that just points out really that if you look at the middle pie chart, that particular study showed that the impact of healthcare on morbidity and mortality is probably only 25% of everything else. And so it shows the massive other factors that we really need to think about affecting. And so when we're implementing online consultations and other new services, we need to think about how do we empower patients, people, to actually change these other environmental and socioeconomic factors. So there's these three considerations, and they all overlap, and I think online consultations can sit right in the middle there, dealing with social health as well as those self-care things. And the reason why I'm finding that it helps us with self-care so much, because we can actually understand a lot more about people because they're willing to put a lot more online, whereas sitting and listening to people, you don't always get that much. So this is the NHS, and it's well worth watching that video around self-care. So our model, this is a busy slide that I wouldn't want you to read in isolation, because you can't. The harsh fact for us is that most of the practices didn't want to do online consultations. A lot of them had seen this kind of waterfall of demand when they opened it up, and they drowned and they kind of closed it off again. So the practices in our locality weren't, and still aren't, a lot of them using online consultations as much as they could. So we wanted to focus on ways in which we could open that up kind of gradually, but also deal with things that really made sense to deal with online. So if we kind of zoom in, you can see that if a patient wants help from a GP, they'll either phone a practice and that continues as normal, or they'll use Engage Consult. All of the administrative things are still pushed to the practice in the way they would, but that tends to happen a bit more quickly over Engage Consult than if they're waiting in a phone queue. What we decided after the initial launch was that the patient complaints fell into two broad contexts. One was people that needed very urgent response, and that often led to lifting a phone, and that created this kind of a split in service where patients who are happy to wait on the phone got a worse service than Engage, and it kind of led to this push towards the unmanageable demand. So we made a decision to actually only meet the routine demand. So patients have to agree that they are happy to wait up to 3 days. And that was based on feedback that we looked in the GP survey that comes out every year. And at least 2/3 of patients say that they would be happy with a response within 3 days. And that's why we chose that. And we, in order to make practices happy, we've put a limit of about 1 per 1,000 registered population in a practice. Then to that query, the admin team are empowered to just kind of bounce back to the patients a little bit, to say, well, I think you might need to put a bit more detail in, or send a photo. And this is around checking about patient ability to be empowered. So if we're going to use Engage Consult to empower patients, the patients need to be ready to be empowered too. So we are relatively strict in saying to patients, actually, I think if you're going to have a successful online consultation, we need a little bit more input from you. And if not, then it goes into the traditional pile. So this is just them focusing on what happens at SDHC. So the practice will push their consultations into the federation, and then we've got one GP per practice who spends approximately 6 hours a week per practice employed for that practice, and they flexibly log in. So these are GPs who have other roles, can work their Engage Consult time around their personal and professional life, and will log in and answer those queries, and often have a consultation that extends over 2 or 3 days. And then they will close it. If more is required from the patient in terms of an assessment or something, then that goes back to the practice. So I think I've covered the main principles, being routine requests, and that's mainly because we found we couldn't get GPs to provide a service that met urgent demands, but it also is more likely to be complaints that can be dealt with entirely online. We have focused on wanting it to be efficient. If it's less efficient than the traditional way, then it didn't make sense for us to do it, and that's also fed into this design. and also, as I've said, around empowerment. Also important for us, though, is about minimising the inequalities, because if people can log in online, we were keen that they didn't therefore just speak to a GP sooner than somebody who can't, and that was another reason for having that kind of pushback, really, to make sure it is, if they're empowered, if it is more efficient, etc. So some of the examples that work really well in this system, things like acne, menopause, ADHD, these are tangible examples that I've had where patients have either, in the first case, sent a picture, I've sent them some information. It's taken me a couple of minutes to give them a link to some information, and they've come back and said, thanks for this. I've read it in detail. I know these are my options. I would like to try X, and I've gone, and it's taken me 2 minutes to prescribe them what they wanted to try next. Sick notes, again, easy to do online. And then again, follow up to things when someone has been examined, and you don't need that telephone and face-to-face element, but the follow-up is then just more simple for people. So I've done a really quick whistle stop through those. I hope people have managed to take in some of it. Happy for questions, or if you wanted, Catherine, to go on to Mark and questions after.
Thank you. No, that's amazing. Thank you very much, Nick, indeed. If you do have any questions, please do pop them in the chat or pop your hand up. One of the words that you used there a lot in your presentation, Nick, was empowerment. You know, talking first of all about how there's a shift for us as human beings, as individuals, to be empowered to make the right choices for our own healthcare, even if we aren't necessarily because we're eating too much. But you also talked about how Engage Consult is empowering your patients. They understand the timescales in which they're going to receive a response, and also your admin team to know that they can push back to the patients. How is it also empowering GPs?
So I suppose the first thing that we touched on was empowering that flexibility of work. So there are actually quite a few GPs who are keen to do more work but can't commit to a regular slot, for example. So it's empowered them to actually provide more health care bandwidth. Second, it does also help in terms of the quality, I think, in the sense that if I'm in a consultation with somebody and they ask me a question, I'm more likely to give an answer rather than allow them to discover an answer, which is more powerful for them. So it empowers me to empower them, but it also empowers me to look up those guidelines. Okay, actually, I'm committing this to paper. It's a little bit more rigorous that I go, I think I'm going to look up that guideline, or not kind of wing it, as people might say. So yeah, I think it empowers us to be a bit more rigorous and build that into the consultation too.
Fantastic. Thank you very much, Nick. Michael, you've got your hand up.
Thank you very much, Nick. Just a question about sort of, GPs flexibly log in. Do they log into the practice? Do you encourage home working, remote working to allow your GPs or indeed other members of staff in order to access and look at those requests?
Yeah, so our admin team are all on site in a hub, but the GPs on the whole do it from home. And it might be any time. We've got somebody who is returning to his homeland in Malaysia and is going to continue doing Engage consults. So yeah, really flexible.
Thank you.
Fantastic. Thank you very much indeed. I can't see any questions that have come through in the chat. Obviously, if you do have any questions, please do pop them in. So I'd like to thank Nick very much indeed for his time and his presentation. Do stay, Nick, if you are able to. And I'd like to introduce now Mark Hobson, who is the Associate Director of Clinical Governance at Local Care Direct. Mark and his team have been working on a project which I'm sure he's going to explain to you, but I have certainly heard recently what a big difference this is making to practices in the area, knowing that they've got a team supporting them and that has encouraged them to further promote Engage Consult to their patients. So Nick, thank you very much. I shall hand over to you.
Thank you. So thanks for the introduction. So like I said, my name is Mark Hobson. I'm Associate Director of Clinical Governance for a company called Local Care Direct. Just a little bit about what Local Care Direct is, just to give a bit of context to who we are. We are a social enterprise that operates across the whole of West Yorkshire. We have 17 sites that we work out of, providing face-to-face interventions, as well as several remote sites providing online consultations. We currently hold the West Yorkshire Urgent Care contracts. That's all the out-of-hours work within the West Yorkshire environment, but we also have some specialist services that we take on during the in-hours part of our day. So just as you can see from the slide, in the year to date, we've got 625,000 cases, or 626,000 cases that we've dealt with so far. So quite a high input through a variety of different sort of urgent care needs. And we have quite a mixed staffing as well, from employed staff to sessional staff, and quite regular sessional staff that are able to drop in and work different sessional sort of shifts for us. And some of the specialist sort of services we've taken on, a lot have been quite responsive towards the COVID sort of pandemic and delivering some of the community services out there, but mainly been providing the sort of remote and sort of hub work around that, which kind of leads on to where we came up with the sort of the primary care consultation sort of model, and the e-hub model. It came out of some funding for the winter pressures, and we were asked, how can we release GP time and GP sort of resource to allow them to focus on what they need to be doing and to take away some of their workload. We originally interacted with Engage, trying to look at how we can use Engage within the out-of-hours environment. So we were aware of the online consultation model, and we were trying to adapt it for our out-of-hours sort of service, which we managed to do so. But on the back of that, we kind of looked at how we can offer that support to the in-hours sort of clinicians around West Yorkshire. So currently there's 77 Engage practices within West Yorkshire. So the proposal was to be able to offer, to take on a lot of the online consultations that were coming through directly into them normally, and we came up with a model and won the bid for at least a 4-month sort of project. We allowed up to 300 consultations a day to come into our hub, and that allows us to sort of recruit up to 15 clinicians a day to be able to sort of manage that workflow that's coming in from these sites. We did put the inclusion and exclusion sort of criteria into this. So we were looking for new presentations, new onset of acute illness, or an acute presentation of an ongoing illness. We wanted the low acuity stuff, the stuff that takes time but doesn't require face-to-face appointments, or is unlikely to require face-to-face. But also we did require them to have a fully completed Engage consult, because without that, then we're not adding any sort of benefit to the system, and we're not actually taking any of that pressure, because it's still going to take just as long for us to be able to manage that patient in the hub. Some of the exclusions obviously counteract the inclusions, but the ongoing long-term conditions, repeat around the same presenting problem, we wasn't wanting to set ourselves up as a GP practice, so we don't want to have those ongoing conversations. Likewise, the admin side of it as well, so referrals, med3s, that side of stuff, we wanted that to stay within the practice. We didn't want to start taking on medication reviews and prompting that sort of stuff. Or any patients that had directly requested a face-to-face appointment, we kind of thought, well, we can't offer that. There's no way, that's out of our sort of remit. So we want to just put them in the exclusion criteria straight away. So as the model sort of shows, there's sort of 3 routes in. What we have found, there's a reluctance, as Nick suggested within there, that a lot of GP practices aren't using online consultations. They're hiding it away. There's a requirement for it to be there, but they're not actively engaging with it because it is bringing in a lot of work, and they don't have the capacity within the surgery to provide that. So there was a lot of reluctance to what we can offer because they don't use it. And therefore, so we actually spoke to the CCGs who directly identified some practices for us to start with. And we did a stepped model approach and increased GP practices every 2 weeks, adding in more whilst we were increasing our staffing model. So we have the patients that naturally complete the online consultations within the practices. They will land in with the receptionists, and they can make the decision whether they send them through to us in the hub. We are seeing now that GP practices are asking patients to fill in online consultations. They're moving the link a little bit further to the forefront of their websites and directing patients there because they can't offer acute on-day services. So they know that this is a way they can access us. So in the consults that we're getting, we're often seeing the receptionist has asked me to fill this in. Can you please, so we know that the practices are asking them to sort of take this on. And we still have our out of hours sort of service as well, where we're sending requests out to patients that are accessing the out of hours to do an e-consult. So those three are our sort of direct routes into the hub. The consultations are obviously received directly into us. We then check for concordance that they do meet the criteria. We also check that there's photos present. Often they'll put that they've got the severe rash or they've got this and the other, and they don't have any sort of reference guide with that or photo. So we then contact them directly to say, have you forgotten? Will you please add one? Otherwise, we're going to have a lot more back and forth further down the line. So we try and nip that in the bud from an admin side of things, saving clinical time up front. And then once we have all the information we feel we need, we allocate that to a clinical list. With regards to that, because of the service that we are and the way that we can operate with sessional clinicians and regular clinicians, we have that flexibility for clinicians to work how they want to work. So we have that access to a part of the GPs that can't do regular practice or that are able to work in a different way and work ad hoc in the time that they require. So we've got quite a decent sort of uplift on staffing and actual people interested in this, and we were able to staff it quite well, which was quite surprising with the current sort of struggles that we're all having, I think, with staffing. But then once it hits the clinician, they obviously review the consultation, contact the patient. So at the beginning, we've always got a patient contact, even if it's just to confirm what's been put on there and we know what the management plan is. We always contact the patient currently to find that management plan out, and then we get to our obviously 3 sort of solutions. So because we have up to 77 practices that are feeding into us, we need that feedback loop to push back out so the practices are aware that we are finishing these, or if they do require any follow-up, there is that loop back in there as well. The majority of our practices, we operate on System 1. So we operate on that, and so do they. So we can task back into the practices, and we have that sort of communication agreed with each practice that we sort of set up with. We also we can close cases but require follow-up. So we make that agreement with the practice that if we want bloods, if we want that, we can't arrange them, but we will send that task through for one of your duty doctors to arrange and to get that sort of follow-up as required. And likewise, if we have to push back for a face-to-face, we do so, but with a time frame that's realistic. If it can wait 24, 48 hours, we put that in there, and the practices agree to sort of to stick with that with us. So like I say, it's taking time. We're only kind of 3 weeks in, 4 weeks into sort of how we're working. We've just gotten our second trial, our second addition to GPs. And some of the other practices are contacting us now prior to us going to them because they're hearing from their partners and their other practices in the PCNs that we're operating. They're wanting to jump on a little bit earlier now. They're hearing the benefits. Last week we only did 290 cases, but that was 290 cases that weren't sitting in primary care. So that was the ability that we had to sort of to just free that up, and then how that practice decide to use that time is obviously down to them, but we need to make sure that we are being effective. 12% of what we receive in, we have referred back to the GP practice, needing a face-to-face. And 20% of what we receive in does require some sort of a follow-up. So whether that just be bloods or an appointment in 2 weeks, x-rays, things like that. So there is always that sort of ability, but what it tells me is that 80% of what we're getting, we're closing with no further action. So it is not looking at representing back into a GP practice for that episode of care. So it's quite a high success rate for us. But what I also has been working on is the more we're getting used to the system, what we're seeing is the more that the admin staff and the front end staff are understanding what not to send us, and therefore our return rate is getting less and less as we go on week by week. So we're getting and building that picture of how that's going. To be fair, that's it really, is a whistle-stop tour of what we're doing and how we're sort of working with Engage. It's enabled us to sort of build in some additional tech that we've been able to utilize, some cut-off switches and things like that, which help specifically with this sort of hub and spoke model that we're trying to sort of work. We are only a pilot doing this, and we are only funded till the end of March because it's obviously a non-recurrent winter funding project. But we're hoping we can show there's some sort of benefit to this and some sort of ability to move this forward in the long term as well.
Fantastic. Thank you very much indeed, Mark. That was really interesting. You're using this in a slightly different way, as I alluded to right at the beginning, to how SDHC are using it, and then there's some conversation going on in the chat, which I'll pick up on a moment. One of the key questions I wanted to ask, and as I say, as I'm going through, if anyone else has any questions, please do raise your hand or pop those questions in the chat. But what I wanted to ask, Mike, you said about, these consultations need to be completed fully by the patients. That's something that the practices are educating their patients on doing. I wondered if you knew anything about how they're doing that. How do the practices get the patients to fully complete the online consultation?
So at the moment, I think so the ones that they're asking to go through this sort of pathway with us, they're explaining that to them straight away, and the fact that please go and fill this in, but please make sure you complete it to the end. Otherwise, we won't be able to refer you into the service, and you'll sit with us, and we might not have the capacity to deal with you for up to 3 days. So they are explaining that to them as of what the benefit of that is. Some of the patients that are hitting where they naturally filling them in and they're not fully completing them, they're going back to them and just saying, if you do it again and complete it fully, we can probably put you down a different route, which means we can get you seen today. If not, then you'll still sit in the normal sort of route to be able to do that. As we know, patients like to do as little as possible to get the result that they want, and it is difficult, but when they just write in with a one line and then end the consultation there, that doesn't really add anything for us, and therefore what is online consultation adding to the sort of process? We're allocating less time per patient to these in our lists because we're wanting to get through them, and we understand that with a full consultation it should take less time to see and fully assess the patient, because we have all the information, their expectations, ideas, concerns will all be presented up front. When that's not there, then you might as well just slot back into a normal GP slot, essentially. So there's no time savings or efficiency there with that. So it's just around the education.
Absolutely, that's brilliant. Thank you. And I think that actually, the carrot there for the patient on, if you do this, then you will be seen quicker is a real incentive to the patients to use the service. Thank you. We've got some questions in the chat. Michael, you've got your hand up. Would you like to ask a question first, and then we'll go to the chat box?
Yeah, thank you, and thank you for the presentation, Mark. So just thinking about, we've seen one aspect from the presentation earlier by Nick from a GP side, and we've seen the ability to close off 80%, the vast majority of those consultations. So we've heard some of the advantages for you guys, but sort of on the ground. So I know a couple of our attendees here are either GPs, practice managers, work in practice. What are people on the ground saying in terms of that online consultation piece, whether anecdotally or quantitatively?
Yeah, so anecdotally or having speech, like I said, we're having now people. So initially when we first put the call out, we put them out to the practices, put them out to the CCGs, very little sort of reaction, very little wanting to get involved in the project. as soon as that message got out there that some of these practices were getting free consultations and they were able to move their patients away, and they were literally freeing up a full clinical list a day, being able to move it out, then it quickly got around to, well, how can we do this then? How can we access this sort of service? So we had a plan where we were only putting 9 on every 2 weeks, and we were building our way up, and then we had a list of practices we were putting on, and now we're having different ones saying, I want to start earlier, where our access is currently really struggling. We're not getting them in. We've got some practices who don't have access problems at all, and they're working really well, and therefore they're not using us, and they're managing their own sort of patients, which is brilliant. But I think for the ones that are having access issues and are having long waiting lists, we want to take just that cream off the top, really, just to say, well, there's this lot that you don't have to manage that shouldn't be a problem, really. You know, we can just get rid of these and let you focus on the ones that are a little bit more difficult, a little bit more complex, and, you know, do what you should be doing really down there. So it's getting a lot more positive now, and obviously the use is picking up. So.
Yeah, as I can say, yeah, what happens if you're a victim of your own success, where you right, I'll try and transfer as much as possible. I guess that's a problem between you guys and the commissioners, in terms of, you know, people just making sure that, oh, you know, here's quote unquote spare resource, I'll just try and transfer as much as possible across to you.
So we absolutely have had some practices say, do you know what, this is fantastic, we absolutely want to use you, but our fear is you stop in end of March, beginning of April. And if we go and promote online consultation, and we go and promote all this sort of stuff to get this work that we want to move to you, then we are going to get it in, and then come April, you're not there. So who is going to do this? And they're worried that it's still going to be present, and they're going to have to do a lot more work then stopping that flow. And I absolutely appreciate that, and, you know, that is something that we are trying our best elsewhere. But that, for me, that I just see that as a positive in the fact that, you know, there is a need there that people do want to access us via online consultation. They, you know, the fact that when we put it out and you started it, they were getting influx and they couldn't cope, means that this is a way people do want to interact with healthcare. The problem is there isn't the capacity to deal with that. So instead of stopping them and saying don't do that, but go back to the phone lines, well, what we need to be putting more capacity into how they want to access us and managing it in that way, for true equitability. I guess that's kind of what we need to be putting that capacity there, and GP practices don't have the capacity to put into that. So I guess, you know, we need to look at other alternatives.
Yeah, I think Nick alluded to that earlier, just in terms of that inequality. It shouldn't be the patient who shouts the loudest necessarily deserves, you know, to be seen first, and similarly, it's not the patient choosing the first, you know, the best particular route shouldn't be seen first as well. It's that quality of that service and how you apply it equitably across that entire patient population as well. Okay, thank you.
Thank you. We've had some questions come through, which is fantastic. I'm going to start from the top, and in case you have missed the questions that have gone up there, I've seen that there has been a conversation between Becky and Nick and Neil as well, I think. But Becky, I wonder if you could, you've asked in the chat there to Nick, you know, do your engaged consults come into the practice engaged inbox first or straight into the hub inbox? Would you mind, Becky, just joining us and explaining a bit about why you asked that question? And,
hi.
Hello,
Sorry,
thank you.
Hello. I don't have a camera, so that's probably a good thing. But anyway, so you've just got me on voice. We're thinking of doing something. I'm currently working across 2 different practices. Well, one's a PCN in Bexhill, and the other is a practice in Seaford. So with the hub that we're trying to set up in Bexhill PCN, we've been thinking through with Michael what's the best kind of model to use, because we really want to take the weight of dealing with the requests completely away from the practices. So we were hoping not to have them coming into the practice inbox at all, but just to come into a central box. But we couldn't think of a way that did that and then, sorry, there'll be a bit of background noise, but we couldn't think of a bit of a way to do that, and also file the request document through to the record and have the accessibility of that record to check the patient's history. So we've ended up sort of going back to the basics really, and just saying that we're going to take over their inboxes and just run them as 3 separate practices. So that was kind of why I was interested really. So I can see that the requests are going to be passed on to the hub in SDHC's case, but then I suppose that then begs the question is, how do they get access to the, they may well have access to the patient's record through another sort of data sharing agreement, but presumably they can't file the information. Oh, I don't know. How yes, I suppose what I'm saying is, how can they file the original request document somehow to the patient's record? Can't really get my head around that. I'm going to put myself on mute because it's a bit noisy.
Thank you very much for explaining that, Becky. I'd welcome any input from that, but Michael, I think if you could pick up on that. I know you've been having some conversations about how that would operate in practice.
Yeah, I think it's primarily from an EMIS perspective. So Mark said earlier, the practice use System 1. My understanding around System 1 is you have that community view so that you're able to view those records wherever you are. However, for that particular instance of EMIS, for the patient to be able to appear within a PCN view, for the PCN to be able to pick it up, they would need to create an appointment first for the patient and effectively initiate that consent or data sharing in order for it to pop up at the PCN's view. So it seems like it's a perhaps a restriction in terms of the clinical system for obviously good information governance reasons why they can't do it. But I guess it depends upon what clinical system you have in place and what you can or can't see, depending upon how it's set up for your area. So no, certainly for System 1 and Community View and for Vision as well, there are some good ways they can view requests coming in from a PCN wider practice perspective. But unfortunately, it might be more of a clinical system, but I might need to either bounce back to Mark or Nick in terms of what you've seen from an EMIS perspective in terms of how to view those patient records. I guess that's probably not a hard one for you, Mark, because you could just see them.
Yeah, well, we do have EMIS practices that use them. To be fair, it is more difficult for us because we don't necessarily have full access to the EMIS records. And we do get a look at the sort of the basic sort of information that we need, and then we have to rely more on what the patient tells us. But because we are focusing on dealing with the acute sort of presentation, very rare that we really have to delve into a lot of history or background with regards to that. If we need to check bloods or things like that, we can always push that back to the GP. Acutely, we can usually, because we're experienced in the out of hours work, where really all our clinicians are really experienced in being able to just deal with someone acutely and move them on to the next sort of phase, really. So for us, it's not a major problem.
Thank you, Mark. Nick.
Yeah, so there's a few options that we explored. We already have a remote consultations hub, so we'd have to do exactly what Michael described in terms of booking an appointment. Then it opens their EMIS up in one instance, but then also the automatic connection doesn't work, so you have to manually upload the PDF of the Engage consult in that way. So we moved away from that, and what worked quite well is that we have a lead GP for each practice who's given direct access to their EMIS, and a couple of backups who also do, and so they and that also allows for those nuances between practices. So that's how we work, as if they are part of that practice. There's a new EMIS coming, which is called EMIS copy consultation, and we were told it would be here in October last year, so who knows, it might be here by 2025, I don't know. And that will, I think, work in similar ways to System 1 for us, I'm hoping. So that will change our model a bit.
Fantastic.
Yeah, and I think that's how the PCN is working. They are operating as separate practices and having those separate instances to let them view, because they don't have that with that shared record view.
Thank you, Nick. Becky, does that help?
She's just typing.
Yeah, no, I was just going to say, because it's so noisy here. Yes, that does help, and it kind of confirms that we haven't missed a trick. But I think, as Nick was saying, you know, there's more stuff, you know, developments coming along that we will need to keep an eye on. It's just a wee bit clunky at the moment. Yeah, thank you.
Thank you, and I apologise, you can't turn on your camera. I'm sorry about that. I did try and change the settings, but
I don't have
apologies
one,
for that.
no.
Bless you. I'm going to pass now to Lucy King from Langport, who's asked the question, building on that question, would this hub be staffed with GPs already existing in our PCNs? Lucy, would you like to join? I don't know if that question was directed particularly to Nick or particularly to Mark.
Either really. So our issue is more with demand and capacity. So if this was something that needed to be staffed amongst our PCN, amongst the GPs that are already working for our PCN in each individual practice, it wouldn't necessarily be feasible to take them out to do this additional triage. So that was the main reason for the question, and whether that would be additional or whether we would have to make room for that.
I think, and Mark, forgive me if I'm wrong, but in Mark's case, obviously this is, you know, extra sessional stuff that he's able to employ, so it's an extra resource for you. I have heard of other PCNs talking about hiring a GP who will then be their lead clinician for anything that's coming into their PCN hub, but certainly, you know, in different areas that may vary.
Okay.
Michael, you've got your hand up.
It's just to say that the main thing which drives this is around the collaboration with Engage Consult. So that ability to be able to share requests, not just the PCNs, but also additional surgeries as well. So it might not necessarily be GPs. It could also be AMPs or paramedics, or, you know, especially within the PCN model, you know, podiatrists, dietitians as well. So again, you know, anything where you do have resources and you're working together as a PCN, that, you know, this hub and spoke model does work. It doesn't specifically need to be a GP. There are other resources. That might even be an admin team if you've got a, you know, staff shortage or power cut or something like that.
Okay, brilliant. Thank you.
Thank you, Michael. Mark, I'm going to come to you first, please.
Yeah, I just wanted to reiterate that I think we operate an MDT model, so we have a whole raft of different sort of clinicians that work within our hub. The ability that we have en masse to be able to take these means that we can utilise those sort of different clinicians. It's cheaper model to be able to run a mixed staffing base, but because, like I said, we have quite a lot of GP practices feeding into us and a lot of e-consults coming in a day, we can allocate those out to the correct clinicians, and get, you know, the complex ones up to the GPs, you know, and just really sort of mix those out there. We're also tapping into a different lot of staff that remote working, that also want to work in a hub with us, you know, so we're really utilising everybody's availability currently, to be able to provide sort of a consistent, steady service. So these are GPs or any practitioners that can't routinely fit into normal working patterns, let's say, because of whatever reason. So we're still using their skills. So I kind of, it's currently working really well for us on that sort of a basis when we're looking at staffing hubs like that.
Thank you, Mark. David.
Yeah, just to mention, we've also got a service operating where the guys providing the online consultation support are based about 30-40 miles away from the PCN. So again, just thinking about, do they have to be in the locality, or could you actually use staff that are widespread around the country, is another way to think of it.
Fantastic. Thank you, David. We have a question as well from Kath McLennan. Kath, I'd like to invite you please to sort of explain a little bit more around that. But you've said here, any tips on encouraging staff to use video consultation more? Is there particular resistance from within your practice, Kath, if you're able to join us, it'd be great to hear a bit more about what we can help you with there.
Looks like Kath might have left.
Okay, no problem. But yeah, I can see you've given us some advice there, so that's brilliant. Thank you, Michael. I'm conscious that we've got only 11 minutes left for the practice user group today. It has been amazing hearing both from you, Nick and Mark, on the different ways that you're using Engage Consult. I'd like to hand now to David, please, who will be talking through and showing you our bulk messaging, which has just been released, enabling practices to send messages out via SMS to multiple patients. David, thank you.
Thanks, Catherine. Hopefully you can see my screen. Just a quick recap,
Yes.
just in case anybody doesn't realise. Engage Consult does now allow you to send outbound messages to patients, so you don't have to wait for the patient to send you a request before you can start the conversation. You can send those by Engage messaging or by SMS. Until recently, that was just single use, so you just send it to a single patient. We now have the bulk option as well. So the difference really between the two options, if you send it by SMS, you're really just sending out information that is non-patient sensitive. So it might be booking for your flu jab, you know, that type of thing. If you want it, you can send an Engage message, and with that you can actually include a questionnaire as well. So if, for example, you've got an asthma review clinic coming up, you could actually just send a message out to all of the patients that are in the that are due to be attending in the next week or two, and attach an asthma review questionnaire and just ask them to complete that before they come in, so you've actually got that information from them before then. So I will quickly now just show you where it is and give you a quick demonstration. So I'm on the request page here, so I can either go and click on create and create an outbound message, or if I go to the menu, go to outbound messages, there's a list of all the messages that have gone recently. So I just go to create message. I'm sending this to multiple patients. How am I going to send it? I'll just show you the Engage message. And then how do you want to notify one? At this point, it's going to be by SMS. So if
I'm not seeing it. Sorry, I'm not seeing anything. Is anybody else having the same problem? The screen's not changing for me.
I can see.
It's
I
okay
can
for
see
me.
outbound patient message, and David's on SMS and is there.
Apologies.
Up below, yeah.
To me.
Okay. Good. So I'm just going to drag a file across. So that's actually got 3 recipients in. And you can see here I can actually choose from the list there. So if I just go asthma, so I could go for an asthma review questionnaire, and then I can add an attachment as well if I want to. So for today though, what I'm going to do is I'm just going to send a quick SMS message out. So I'll do the same again. People are watching, I can't type. I can put a website on there as well if I want to, but I won't for now. Again, you can add an attachment if you want to this, and then just click send. You can rename it if you want to, so that's actually what it's going to appear like in the log. And then there we go, that's now been sent. So you can see with bulk, we're actually saying it's gone to 3 recipients, 10 recipients, 1,000 recipients, however many it is. What we actually do with bulk, as opposed to the single at the moment, although single is going the same way as bulk, is we actually put it in a queue to be sent, which is why this is pending at the moment. And we check the queue every 5 or 10 minutes, every 5 minutes, to see if there's anything to be sent, and then we send it off. So at the moment it's saying sent pending, and it'll stop like that for a bit. But I can then drill down into that bulk message and actually see individually what's happened with each of the recipients to the message. So if I just pick one, I can go in there and you can see there it's telling me when it was sent, whether it's been received or not, and what the message was as well. When the message is sent, there will also be an entry in the journal or a consultation for EMIS, which will actually have the message in it. So you can just look in the journal and you can see the message that was sent to the patient as well. So you can either come into the engaged client, or you can go into your clinical system and you can see what was sent and when. So this is going to remain pending. So I wouldn't advise we just sit here waiting for that to change to yes, because it could be a few minutes and we haven't got long left. But yeah, the flexibility there is, like we say, is you can either send it by SMS, at which point you can just send out bulk messages about non-sensitive information, or you can actually send out an engaged message. And the key benefit there is you can actually attach questionnaires. You can put attachments on both, by the way.
Great. Thank you, David. And hopefully it's just a good example of what we're trying to do in terms of making sure that we are delivering based upon our roadmap. So we've seen single sign-on, we've seen that bulk SMS messages, there are a number of other things as well. And that's the whole point of this group here, to give you early eyes on what we're doing, understanding of sort of our focus, but also an opportunity for you to ask those questions and help us refine what this roadmap looks like as well. So thank you very much, David. I guess any questions around bulk SMS?
We have two that have come through. We've got one from Becky there. Thanks, David. Are the sent messages coded into the clinical system?
Yes, is the answer. So we code it depending on whether you've sent an SMS reminder, an SMS notification, an SMS, or an email. It'll be coded appropriately. So yeah, it's always coding stuff. And again, the questionnaires. So something like the asthma review questionnaire, for example, that is also coded as well. Again, if you look at something like GAD7, PHQ9, they're coded.
Fantastic, thank you. Laura, I think that may have covered your question as well, but please do shout up if it has not. I'm going to take that we've covered that there, that the coding is in there, so that's fantastic. David, thank you very much for that presentation. Lovely, thank you, Laura, for confirming. Thank you. Thank you all very much for joining us today. I think it's been really insightful hearing how Mark and his team and Nick and his team are using Engage Consult, and it's been great to have all of your involvement and questions coming through here. So thank you all very much for joining. Thank you, David, for showing us about bulk messaging. If there are any questions, please do reach out to me or any of the team here at Engage Health Systems. I also wanted to briefly mention, just before we finish, about our patient check-in screens, which are now enabled with mobile check-in for patients. This is currently at no additional cost. So if you use our software on your check-in screen or have one of our check-in screens and our software, you can enable this at no additional cost. Your patients will then be able to check in via their own devices for their appointments when they arrive at the surgery. Thank you all again very much indeed. I'm going to close this session now. I will be following up to get some feedback, and thank you all for the comments in the chat there. I'm glad you've all found it as interesting as I have. Enjoy the rest of your day. Thank you very much indeed. Oh, Michael, if you can just stay on. A message has come through there from Neil.
Yeah, sorry, I thought I just hijacked the conversation.